Good morning, good morning, good morning, and welcome to the Great Lakes Health Radio program on Power 96.5 FM WUFO AM 1080 AM. I'm Francesca Messiah, Kaleida Health Manager, Workforce Development, and I want to thank you for once again tuning in and listening to the Great Lakes Health Radio program, where I always hope that by the end of the hour, you've picked up a couple of things you didn't know before, and not only for you, but also to share in conversations with your network, Sunday at church or Bible study. But it's all about learning. And today, I just want to share with you a little bit about Kaleida Health. Who is Kaleida Health? We are hospitals. We're hospitals not only in Western New York, we're in Olean as well as Bradford, Pennsylvania. Kaleida Health, you will see labs for blood draws throughout Western New York, Olean, and Bradford, Pennsylvania. We offer outpatient clinics, primary care specialty clinics for all ages, ambulatory services, school-based health centers in the Buffalo Public Schools, as well as around services where the medical professionals, if they're nurses, aides, therapists, come to your home through the Visiting Nursing Association. We're over 13,000 employees, and I'm just very happy that either you are part of our Kaleida system, one of our patients, or that you're considering being one of our patients and one of our many services that we provide throughout the community. Well, today's topic is something that is new to me. It's relatively new in the news, and that's the topic of birth equity. Our guest for today is Rhiannon Needham. Right, did I pronounce your first name correctly?
Yeah, Rhiannon.
Rhiannon.
Mhm.
And Rhiannon Needham is with Kaleida Health, and she is the birth equity coordinator. So today, our topic, we will be talking about birth equity coordinator and how it supports the diversity, equity, and inclusion initiatives that are part of our fabulous Kaleida Health system. Welcome to the show, Rhiannon.
Thank you. Thank you for having me.
Oh, you're welcome. And the first question, if you could please explain what is birth equity and why is it important for the hospital system, for Kaleida Health, to have you as our birth equity coordinator?
Sure. There's a very specific definition that's kind of all-encompassing of what birth equity is, but at its core, it's really ensuring that all people, doesn't matter their race, ethnicity, socioeconomic status, or any other factors, have sort of equal access to quality health care, and especially reproductive care during that pregnancy, birth, and postpartum period. Uh, we do focus, there are definitely healthcare disparities in certain populations, depending on where people live or sometimes related to their race, ethnicity, or socioeconomic status, especially when we're thinking about insurance factors and things like that. But ensuring that people in any reproductive phase have whatever resources they need to be successful. And I would say that really the main thing I think when people think of even just the word equity, not necessarily related to birth or maybe related to birth, they might think equality, which can be a little bit confusing, but really what we need to focus on more than that is everyone having the resources or support options that they need for their individual needs or requirements and kind of leveling that playing field instead of bringing in and making sure everyone gets the same thing or same treatment regardless of who they are or what their needs are, because that's not always necessary. Just to answer your question of why it's important, in our healthcare system is, and I think important all the way across our country, but especially in New York State, is some of the disparities that certain populations have, especially in our Western New York region. We are Buffalo is the largest city outside of New York City. So we have a pretty dense population in some of our areas, and they just have different needs depending on, as you mentioned, we're out in Olean too, depending on if they're in a rural area or an urban area, and what healthcare options are out there for them.
So then would you then say some of the rural communities and urban communities face some of the same healthcare needs?
I would say that some of the same and then some very different. The access is absolutely going to be different for each of them. I mean, people who live in, let's say, downtown Buffalo, this medical district that we have down here is pretty dense, so there's a lot of different options. However, they may need to there's parking issues down here. They may need to take public transportation. They may need to get dropped off, especially if it's emergent care. Whereas the opposite out in Olean or other rural areas, they might have to be driving a pretty far distance just to get basic care. So that is a huge difference, but I would say that there's still the same need is still there. Just because you live in one area doesn't mean that you need more or less care, just because of what's out there.
And that's true. Good healthcare is good healthcare, and we all need good healthcare. So yeah, no, I agree, and I'm sure our listeners would also agree. Birth equity. What departments do you collaborate with, and do you collaborate with departments across the system? I mean, I know you're located, I believe, at Buffalo General, but do you collaborate with like Millard Fillmore Suburban or
Uh,
Olean? Or, yeah.
yeah, I do. I cover with most collaborate with mostly the maternity departments at each of the hospitals. So at Millard Fillmore Suburban, Oshai, and Olean. Uh, my office, like you said, I am housed at Buff General, but I don't really do much with the Buff General population because there's not really birth going on here. They usually will go shy if they come in. So I do collaborate with the maternity departments, which would include labor and delivery, the mother baby postpartum unit, and then maternal fetal medicine that's here at Oshai, across all three of the hospitals. And then I also collaborate with some of the outpatient clinics, like the Kensington Clinic, Niagara Street, some of our GPPC OBGYN clinic affiliates that we have. I
And
do some,
what is GPPC for those who may not know?
oh yes, it's general physicians. It's their They are a Kaleida affiliate, so we are aligned with them, and there's a lot of not only OBGYN, but primary care practices and things that are under the general physician umbrella.
Yeah, I just wanted to make sure. I mean, I know what general physicians is, and I just want to, and it's a relatively um, new collaboration that Kaleida Health has developed, and they are um, physicians and medical practices, physician clinics for men, women, children, again throughout the Kaleida system, and a large one right here in a block from downtown Buffalo's. Um, so, what were they doing? What were the departments doing before birth equity? Before you came along as birth equity coordinator, how were they keeping track of, you know, and what are they keeping track as? I didn't ask it. What is it that you're actually keeping track of?
So what before me, I mean the departments, they all had their own individual ways of kind of tracking information and looking at essentially birth outcomes and experiences across the board. So they usually do look at data points related to if it's um, broken down by ethnicity, age range, socioeconomic status, any of that. They'll look at those specific population areas and then determine if there are disparities within their individual hospitals and how to kind of improve that. So generally overall kind of looking to improve outcomes and experiences for the people who are experiencing those healthcare disparities. Um, Before me, and they still are. I absolutely did not come in and take over anything. I'm just mainly here to support and provide some additional education and ensuring that the system is kind of doing all of what we're doing in a cohesive way so that if Oshai is doing something really wonderful and Suburban is looking for resources or ways to improve that in their hospital, I can kind of bring them together and offer that collaboration or be a liaison between the facilities. And then same thing with Olean and just looking at everything from a system perspective rather than individually is I'd say what my main involvement is. But before they were still working on all of this on their own. They might have just had to do it in different ways because there wasn't somebody necessarily specifically designated to do this work. Uh, but they have been a part of the New York State Birth Equity Improvement Project, which is a state initiative for many different hospitals where people give birth. And that project looks at many different things like improving outcomes and experiences. And that data is tracked through patient surveys and then reducing C-section rates and things like that. That project focuses on a lot of different things that both Oshai and Millard Fillmore Suburban were a part of long before I joined the system. So they have been doing the work. There's just now somebody who, like I said, kind of helps to bring that together and look at these are the great things that we're doing here. Maybe we can do it here as well.
And the who is you,
Sure.
right?
Yes, yes.
You
That
are the
is me.
who.
Yes.
So when we talk about, and you've used this term over and over, birth outcomes, you did talk about C-section. What are some of the other things that are looked at? And is it C-section? How many people are having C-section, or the outcomes of C-section? So just, so besides, we talk about birth outcomes. Are we looking at who lived, who died? Are we like what are we looking at under birth outcomes? What are you looking at?
There's definitely the maternal mortality piece, which is are people dying during childbirth or in what we call the perinatal period, which is during pregnancy, birth, or one up to 1 year postpartum. We're looking at kind of is that happening? If it is, why is it happening? And also the who, because we need to look at and address if one specific population group is experiencing more either issues or higher rates of maternal mortality dying during that perinatal period. Is that something that we need to address? And really, the answer is yes. Not necessarily at a system level, but looking at the numbers for the state and nationally, there is evidence out there that certain populations do have higher maternal mortality rates, and that's Black women and their infants are usually the rate for Black women compared to white women is 4.2 to 1 in New York State, which means that Black women are over 4 times more likely to die during pregnancy, birth, or that postpartum period than their white counterparts. And when we look at that for New York State, it's really even higher than the rest of the country, which is between 3 and 4 times more likely. So New York State, has this issue that needs to be addressed, which is why there's this state improvement project that's going on, because it's obviously not just a right here Buffalo problem. It's with New York City having such a large population, there are other areas of the state, but it is something that we acknowledge. We live in New York State, we work in New York State, and it is something that we have to address.
Yeah, and I believe that is something that a few months ago I did see Governor Hochul announce that a new committee or panel, a new committee to discuss birth equity. So I did see that news clip.
Mhm.
Birth equity, is it considered a social determinant of health and why?
I would actually say that a social determinant of health relates to birth equity. So kind of flipping that around. So social
Okay.
determinants of health are the conditions we live, work, play in, our income, education, access to safe housing, food, access to healthcare, all of that. And all of these things play a major role in reducing our disparities or what you could call achieving birth equity. I mean, we're always striving for better, but achieving birth equity because they're all influencing our access to prenatal care, nutrition, our social support, which is our families or community members, overall health during pregnancy, stress levels that could contribute to our blood pressure. All of that is directly impacted by our individual social determinants of health. So I would say that they are related, uh, but social determinants of health play into birth equity.
hmm And you know what? I don't think we've had a show in a while on social determinants of health. And I believe that comes under your department, diversity, equity, and or does it? Does social determinants of health come under diversity, equity, and inclusion department?
Yep. Yeah. I mean, there are a lot of people involved in it. There's a committee related to it that does involve our department, but it also involves social work. Social work has actually taken over a very big percentage of when nurses or MAs will go in and screen for social determinants of health when people enter our hospitals. That kind of goes further into social work and they determine what next steps are. If people need help related to those social determinants, then they'll kind of address that through the social workers.
And so I was saying for the listeners, you can see how it's a very complex area with birth equity and social determinants of health, and they're all intertwined. Um, if listeners are interested in having you speak at a program, so they better understand, or they may understand, and they want to hear more or learn more about what Kaleida Health is doing around birth equity, what should they do?
So, actually, the best way to get directly involved if you're interested in the work being done around birth equity within the system is we have what's called the Maternal Advisory Board. And the Maternal Advisory Board, it's actually split into two. We have one for community stakeholders, so people who are kind of living, working, breathing this type of thing. And then we have a separate board that's specifically made up of parents, either people who have given birth or their family members within the last 2 years at one of our facilities. And the Maternal Advisory Board, there's a link right on Kaleida's volunteer page to kind of fill out the questionnaire for it. And then it's also on our maternity services page. And all of that, those inquiries come directly to me. And then I contact people individually to talk a little bit more about it.
What was the first committee you mentioned? The name?
It's all called the Maternal Advisory Board. So it's all one streamlined form to fill out. And then when I talk to people individually, we determine if you would fit best on the community side of things or on the parent side of things.
Um, what type of person, I don't know, are you looking for, and how often do you meet? So what are some of the things that, only because I serve on boards and I just had a meeting earlier today, and that's one of the things we were talking about. What's the fit? Is there any type of is there any certain fit you're looking for, or is everyone welcome to apply?
Definitely. I mean, absolutely everyone is welcome to apply. I will say it's not like a what you might consider a normal board where you're kind of voting on a lot of things or things like that. It's more of for people who are passionate about improving these birth outcomes and experiences in our region. And so you could either fall into one of two categories. One, if you or some one of your immediate family members just gave birth within the past 2 years uh, at a Kaleida facility, so either Millard, Fillmore Suburban, Olean General, or Oshai, then that is one bucket that you could absolutely fit into. And then the other side of things is if you are a community health worker or if the work that you do directly relates to birth equity. So we have representation from insurance companies, community health organizations, doulas, and different people who are really just committed to doing that work. That's our community side of the board.
Mhm. On the community side of the board, do you or slash your team, do you ever reach out to different groups, asking them if they're interested in serving? If you're, I mean,
Absolutely.
okay,
Yep. Yeah,
okay.
very consistently.
So community health workers, health educators, those might be some, or like you said, someone who has in your family who's given birth in the past couple of years. I'll need to look at and what page would they go to on our
Yeah,
Kaleida
they,
Health website?
it can be found in two places, and it's the same thing in both places, so you don't have to go to both. But one, if you go to the Kaleida Health volunteer page on our website,
Oh.
there's a link and it says Maternal Advisory Board. Or if you're just looking around the maternity services page on the Kaleida Health website, it's linked there as well. And it's a big box in the middle of the page, so you can't really miss it. It's right there.
Mm-hmm. And when do you meet?
We meet quarterly. So we just had our first meeting for the year in January, and then we'll meet at the top of each quarter. So it's just 4 meetings per year with a 1 year commitment. You don't have to re-up after those 4 visits, and we have a virtual or in-person option.
Mm-hmm. I mean, do you meet during like between 9 and 5, or do you meet after?
Yeah, we usually meet toward the end of the day, but from about 4 to 5. And but I consistently check in with the members as we get new members. If those times don't work for people, then we kind of make an adjustment. But we usually meet right now on Wednesdays. So it's the first or depending on the board you're on, either the third or fourth Wednesday of the first month of each quarter, which is a little confusing to say it that way. But like in January, we met the third Wednesday of that month from 4 to 5.
Mm-hmm. And bottom line, you would go to our Kaleida Health volunteer page and look for
Look for the
first
box that says Maternal Advisory Board.
maternal advisory board,
Mhm.
and then there's probably a contact number and
Yep,
email address. So for the details, you know, that can happen because we're in Buffalo, so it could be a snow day, it could be whatever day, and
exactly. Yep. Yeah. And like I said, it comes directly to me. Go through, it really doesn't even go through the volunteer services team. It just gets directly sent to my email, and I contact people individually to talk about their further interest and uh, their availability and stuff like that.
how about college students who are working on, let's say someone's working on a PhD or a master's. Are they encouraged because maybe this is something they want to write about, get more research? Is this the right place for them, or are there minutes or notes that someone can go to and see what has been done with
Sure,
the
they can always apply. I've had actually college students apply that were looking for volunteer hours for internships and things like that. They can always apply and we'll kind of talk through what their needs are. It might not necessarily be that they sit on the board and in the meetings, but I can have a conversation with them about what they're looking for and how they might be able to best get involved based on that. There aren't public minutes because the some
it's
of the information,
confidential?
yeah, some of the information that the parent side of things shares with us, it
Right.
is confidential information, and we don't want anybody to feel like they can't have that open platform to share.
Yeah, and I just thought of that when after I asked the question. It's a hospital, and we have HIPAA. We definitely and not only us, it's part of the law,
Mhm.
and we don't want to and like you said, we want we're all about build we want to build trust.
Definitely.
Yeah. Um, what are something else that you would like to share that we haven't touched on this morning?
Uh, I really think that we've covered, I think at the very least, the basics of the information. But essentially just, there are these disparities. It's not something that, like you said, Governor Hochul has put out information on it. Recently, there are many committees in New York State dedicated to improving these types of things, especially for our Black birthing people and their families, and just trying to close that gap and level the playing field. So we definitely want to reduce any risks for everyone, but there is a major disparity that we have to address, and closing that gap so that it's not that Black women are 4 times more likely in New York
Right.
State to experience serious complications or death. It's
And I have to admit, not or share, one of the executive director of Buffalo Prenatal, Buffalo Perinatal was a Kaleida Health employee years ago.
Mhm.
And this is a type of work that Luann Brown has been doing within her organization, and I'm really pleased, Rianne, that you are representing Kaleida Health and leading the organization as a birth equity coordinator. How would people reach you if they were interested in having you? I think it's a fascinating topic. So if they want you, they would like for you to come and speak to their group, how would they reach you? Or do you speak to groups? I didn't ask you that.
Yeah, I mean it would definitely depend on what the situation is and of
And how
course my
would they reach you?
ability, but they could email me at r R is in Robert, X is in X-ray, and then my last name, Needham, Needham at kaleidahealth.org.
And on that note, I want to say, Rian, that you have been a wealth of information, and I want to thank you for being our guest this morning on the Great Lakes Health Radio program and sharing the important topic, birth equity. You're the birth equity coordinator, and how Kaleida Health supports the DEI, diversity, equity, and inclusion initiatives with birth equity. And I want to thank you and have a great day.
Thank you. Thank you for having me. You as well.
Oh, you're welcome. And listeners, hold on. We have the second part coming up of our program within another second. And now on to part two. Welcome back to the second half of the Great Lakes Health Radio program. Your host, Francesca Messiah, Manager, Workforce Development. Um, you know, I am so glad that you are listening to our program. And I know if you're a regular listener, many times you've heard me say, we're going to have a part two. And I always try and work on a part two. Sometimes they're more successful than others. However, today's part two is with Dr. Ashley Bernotis. Good morning, Dr. Bernotis. Welcome back to the program.
Good morning. Thank you for having me again.
Oh, you're welcome. Well, our topic for today is obesity treatments, including rapid weight loss medication. Dr. Bernotis is the director of obesity medicine at Kaleida Health. Now, I don't know about you, but I know I've been noticing many people, just who I know, who have recently lost a lot of weight. And I'm thinking, is everybody working out? Like, what's going on? Because I guess I need to join them. But today, one of the areas where we left off back in October of 2024, we began talking about rapid weight loss medication. And if you're like me, you've seen all kind of commercials, not sure what to believe. But that's why we have Dr. Ashley Bernotis on today as our guest. So let's just start off, Dr. Bernotis. If you could just give an overview of what is obesity, and has it always been a concern for society, a concern for the community?
Yes, so obesity is technically defined as patients having a BMI of 30 or greater. We know that BMI is not an accurate measure of a patient's level of fat in their body, as it doesn't differentiate between muscle or fat, but it is unfortunately the only measure that we can use on a broad scale to define obesity. Has it been around forever? Yes, to some extent, but what we're seeing is in epidemic proportions. It's rising significantly and has been over the last 10 years. And with that comes the emergence of treatments. And we can talk about those at just a little bit later in the segment. But there are quite a few excellent treatments that have been around for a long time. And I think with the emergence of newer, more powerful treatments and insurance starting to recognize these treatments as something for health and not necessarily just for vanity, we're seeing a lot more patients reach out and be able to obtain them.
Yes. Thank you. Is obesity genetic?
Yes. So genetics definitely play a larger role in obesity than I think we know. There are current studies that are being conducted at this time, determining the genetics related to obesity and the link between even a slow metabolism and your familial genetics. And so we're finding that patients with a strong family history of obesity and slower metabolism and other diseases like diabetes and high blood pressure, we're seeing that pass down to subsequent generations.
Yes, and I think that's important. That's important for our listeners to know, because sometimes it can be, I'm sure that's where they would see you for an appointment, because sometimes it can be controlled. Just because you've had obesity and overweight in your family for many years, not necessarily big boned, as people like to call it, it can there are things that can be done, and that's another reason why we're having this show, just to talk about this. Now, there are new obesity guidelines. And how do the old guidelines differ from the new guidelines?
So yes, new obesity guidelines emphasize a more comprehensive, individualized approach to treatment, which is actually what we do at our center. Unlike previous older guidelines that focus primarily on BMI and weight loss, newer recommendations consider obesity as a chronic disease, requiring chronic treatment and long-term management. So it also includes managing it from multiple directions, such as medications, behavioral therapy, in some cases surgery, but also through nutrition and exercise.
Nutrition and exercise. That's what I always emphasize, because sometimes people just think they can take, well, the new medication and not do that. Which then leads me into, let's talk about well, you know what, let's just go back to, you just talked about exercise. And if you are obese, um can if you have obesity, can you exercise?
So, of course, you can. To what extent, that will depend on your physical limitations, right? And so, what I encourage all our patients to do is to figure out what you can do that doesn't cause pain, that doesn't cause a large inconvenience in your life, right? Because we know that we all have different, busy lives. And so I said, what can you incorporate in your daily regimen that is some form of exercise, and what would work for you? Because just telling a patient to do this type of exercise and sending them on their way is not going to get them involved and active if they can't fit it into their lifestyle. And so patients with obesity, sometimes struggle because we know that the added weight has an effect on the joints. And so we recommend some lower impact exercises. One of my favorites and one of the best ones out there is aquatherapy or swimming. And luckily in the Buffalo area, we have access to plenty of pools. The YMCA has a pool, and I know local community centers have pools. And they often will have some time where it's either a free open pool session where you can go and swim on your own, or even some classes that you can take. So swimming is probably the number one. And then walking, of course, and cycling. So I always recommend to my patients, cycling can be difficult if you're up on a tall bike, but if you're on one of those recumbent bikes with a chair and you're pedaling, you're exercising, you're using your muscles, and you're increasing your heart rate. So it's a very good way of exercising without putting all this impact on your knees and your hips and your back.
How about electric bikes, like those new electric bikes that they have? Is that what they're called? Is that the proper term?
Yeah, the e-bikes or electric bikes. Yeah. So I think they're wonderful. I think they're expensive. I think they're yes, and I think they're great for getting you from point A to point B. And if you're in Buffalo, not in the winter, and want to be outside, that is a great way to get around because it allows you to pedal. And then when you need assistance, for say you're gone a long distance or you're going up a hill, you need that extra assistance, you can activate the electric part of the bike to help you. That is not necessarily feasible in the winter months. And so I always try to recommend some indoor activities. We tend to be more sedentary in the winter. That is just a known thing as a general population rule. And especially in Buffalo, where the cold weather does not make us want to necessarily leave our houses as much. And so I try to recommend things that people can do indoors at their local fitness facility or in their own home.
Mm-hmm. And I have to also say that some of the exercises, you can also go in your search bar into Google, put in low impact exercises, and you'll probably have a few pages, and there's no subscription fee because some of these exercise apps make you pay for subscription. Also, I want to mention that I know the old YMCA on East Utica, on East Ferry. I can't think of the name of the exact name of the community center. It's a community center. I know it's run by Catherine Roberts, but they have a beautiful pool. And also, I would say yes, Buffalo and the Buffalo Public Schools also have Saturday academies, and some of the schools at the Saturday academies have swimming pools. And I'm not sure if swimming is available or if they have aqua aerobics or something like that on Saturdays with the Saturday Academy, but that's free because the community center schools are free, and the YMCA on East Ferry across from St. Luke's Church. Just can't think of the name of the community center, but I know they have a beautiful pool because I've been looking at some of the pictures and activities on Facebook. So those are just a few more resources, but definitely the Y, William Emsley Y, the Independent Health, all those Ys have some sort of a fitness, aqua aerobics, and their schedules are throughout the day. So I just wanted to add that. Oh, you're welcome. Rapid weight loss medication. I'm seeing a lot of people, they look great. For years, they were heavy and they look like they've lost anywhere from 50, 60, maybe 80 pounds or more. Let's talk about the rapid weight loss medications. And I want to say at the show we did in October, did you mention that there were some medications that were for diabetics and some that weren't for diabetics as we talk about this?
Correct. So I'll explain those just to give you a perspective and to compare it to still the gold standard for weight loss is still bariatric surgery. Okay. So bariatric surgery still gives patients the largest amount of weight loss, and that's a weight loss of about 25 to 35% on average. These medications, these new medications, especially the newest one, come in very close to surgery and can give up to 20 to 23% weight loss. So for a lot of patients, it's a great alternative to surgery. Now, for some patients, these medications will not work, right? So we try them, we monitor them, and we keep monitoring them and following up. And some patients need to go to surgery at some point, at which time we discuss that and we direct them. We actually have 3 surgeons in our clinic as well, who I work very closely with and I would trust completely to perform this surgery. So we can try it with the medications, and then if we always need surgery, we have it there. But in terms of the medication, so the ones that everyone is inquiring about are these GLP-1 agonists like Wegovy or Ozempic. And then there's another dual agonist, which is it's a little bit stronger of a medication, and that is Mounjaro or Zepbound.
Well, you know what? If you could just say that again, because we lost that part. So you said GLP-4, and then you said dual agonist, and then what did you say after that?
Yeah, so the dual agonist medications are Mounjaro and Zepbound. And so Ozempic and Mounjaro are for patients with a diagnosis of diabetes who are trying to also reduce their weight, but it can be just for diabetes treatment alone. And then Wegovy and Zepbound are for weight management alone without a diagnosis of diabetes. And so it's very important to delineate that, because insurance approval will depend on it, as will coverage for the medication and cost. So currently Zepbound and Wegovy are the number one injectable medications and the closest thing to surgery that we have. So what you're seeing with patients having a rapid weight loss, I'm hesitant to say rapid. I do monitor patients. It's much faster than with diet and exercise alone. And I think that's why we see it as a rapid weight loss, because most of my patients have been trying to lose weight for decades, and they go up and they come back down, or they go down and they come back up. And sometimes they go even further than they were before. And things change as we progress in our lives, as our hormones change, as we age, and we know our body completely changes and our metabolism changes. And so we'll see this fluctuation in weight, which forever we called yo-yo dieting or yo-yo weight loss. Yeah. And I mean, weight has been an issue on everyone's mind for decades. As we know, there have been fad diets out there since the 80s that are still poking through now. But what I would say is that finally we're understanding that it is a disease that is treated with more than just diet and exercise. And I think that was the thing for the last 20, 30 years. Patients have just been told to eat less and exercise more. And they were maybe told that they were lazy if they weren't accomplishing the weight loss that they desired. And I think now we're bringing more recognition to the fact that this is a chronic disease, just like high blood pressure, just like asthma, just like high cholesterol. And can they be managed with diet and exercise and improved? Absolutely. But can they be completely treated? No. And that's why the medications come in. When they studied the medications, when they were trying to get them the FDA approval that they have now, they compared the medication with diet and exercise alone and what the weight loss outcomes were. And with diet and exercise alone, patients were accomplishing maybe about a 3% weight loss. These medications give you an average of 20 to 23% weight loss. So there's a whole 20% there that these medications can help with that diet and exercise alone could not do. And that's why these medications hit on these hormonal things. And I could delve deep into it, but basically it affects the hormones, it affects our brain and how we process things at a level that we can't control to help us with the weight loss.
Something you talked about having that you can begin with the weight loss with a weight loss medication, but then you may have to consider having surgery. Can you talk a little bit more about that? Like at what point is that a consultation with the physician?
Yeah, so definitely they'd be following with us, mostly with me, as I do more of the medication management side of things. And what we would do is we would if the patient's preference was to start with medication, we'd start with the medication, and I titrate up. I go up on the dose based on several factors, based on the patient's fat mass loss, the amount of fat that they're losing, based on the amount of muscle that they're retaining, right? Because I monitor that. That's very important for patients to keep their muscle while they just lose the fat, and how their hunger is going. And as we go up on the dose, if we reach the maximum dose and patients are still stuck and they still have trouble getting rid of the last bit or whatnot, we can either persevere and continue on the medication for a while to see if it'll work. But some patients will just plateau, and that's where their body wants to be. And in that case, we would talk about our surgical options to help them accelerate it. And I also, vice versa, I see patients who've had surgery who then tend to regain the weight, which we know is a common thing because it is a chronic disease. Surgery does not cure your obesity. Surgery helps it, gets it back down to a lower set point, and then we can help monitor and treat it as we go along. So I see patients who've had surgery and are regaining the weight, but also patients who are not considering surgery just yet or want to lose weight before and try to see if they can do it with the medication. And yeah.
How long can one stay on the medication?
The medication is actually intended for life. I tell patients, yes, I tell patients, think of it as your blood pressure medication. You don't even think twice about when you're going to come off of that, when you're going to need, we don't think twice about it. When a patient's put on a medication, oftentimes they may just be on it for the rest of their lives. And so if anything, this injection or these medications will actually help hopefully decrease the amount of additional medications you need, right? So you might have to do this once a week injection, but you might be losing a lot of oral, like blood pressure, cholesterol medications, diabetes medications that you wouldn't need anymore because you're fixing those problems. The other thing I tell my patients is that this is a constantly evolving subject within medicine, right? So obesity medicine has really exploded in the last few years. And the medications that are coming out on the market are coming out exponentially faster. So we expect by the end of this year, I think, to have a few more medications already on the market to help treat patients with obesity. And so I tell patients the injection that you're taking today is not going to be the same medication you're going to be taking in 3 years, in 5 years, or in 10 years. It's going to look completely different because it's forever rapidly evolving.
Interesting. Are you aware of any side effects? Someone said something so here's a rumor that I heard, don't know if it's factual. Someone said the medication has affects your stomach, maybe your digestion. Are there any side effects that you're aware of?
Yes. So the medication works through two main mechanisms. One is it tells your brain that you're full, and so you feel that fullness. But the other thing it does is it slows the movement of the food throughout your GI tract. So it makes you feel full for longer because it keeps the food in your stomach for a longer period of time. And some patients can get some nausea with that. And others can get so the main side effects are nausea, acid reflux, and that's usually temporary. And then some patients may get some diarrhea or constipation. And this is what I tell my patients is the nausea should be the worst within about 24 hours of the injection. And it should get better as you continue on the medication. And it may get worse if you increase the dose. Okay. And how to mitigate that and how to help prevent that is I tell patients, make sure you're up on your protein, make sure you have a good amount of food in your stomach. And sometimes that helps with the nausea. What I also see as a trend, and this is just anecdotal from my office and what I see talking to patients, is when they have bouts of diarrhea or abdominal cramping, it's because they're eating foods that are not necessarily the healthiest along with their medication. And the medication is basically telling them that's not a food that you should be eating on a regular basis, such as something high in sugar or high in fat.
How about
and then
wings?
if you have
Like wings or pizza?
Exactly. Chicken wings are not going to be helpful because they're fried in oil. And so that oil will, and I've had patients who report exactly that, chicken wings and pizza, and then they have abdominal cramping in the evening. And if they go back, so I tell patients, if you have that symptom, go back the last 24 hours and audit your food. Think about what you ate. Did you eat something that might have triggered it? And over time, you can make a list of your triggers and try to avoid them. And then lastly, with the constipation, you need to drink a lot of water with these medications because it slows the movement through your gut. You need to keep that moving and smooth by drinking a lot of water so that your bowels can absorb that water and help your bowel movements go smoother.
Wow, that is a lot.
Yeah,
Yes.
there's a lot.
It's a lot. So obesity and disease. What are some of the diseases um associated with being obese, having too much weight on your body? What are some, and does it matter if you're younger or older? I have a friend who, we talk about this often, and I tell her, even though some of, I look at some of the stars who are obese, but I always say that that either they have disease or they could have potential of having different diseases. So what diseases are associated with being obese?
Yeah, so the main ones are so type 2 diabetes is a main disease that's associated with obesity, as is heart disease, so heart attack and stroke. Um, Certain cancers, especially related to the breast and the colon, high blood pressure, sleep apnea. That's a big one, actually. Zepbound, that medication, the one of the stronger injectable medications was just approved in December for treatment of sleep apnea. And so I'm also seeing a lot of patients with a diagnosis of sleep apnea come in, and I can help them get on Zepbound. The other diseases are arthritis, obviously in your joints. Any additional weight on your joints is going to affect those, and kidney disease. And do we see it in all ages? Absolutely. So we see obesity as young as childhood. Like we see it as some of my patients will come and tell me they have never been small. They've always exceeded the charts, even in their pediatric clinic. And they're, maybe they've seen the dietitian or nutritionist when they were with their pediatrician. And so we at this clinic, we treat adult patients ages 17 to 18 and older. However, Oshai Hospital, Children's Hospital, has a weight management program for children, and it's called Healthy Way, and it's led by two wonderful directors, and they treat patients from a very young age with all options.
Yeah, and I had them once on the show a couple of years ago, and after the show, I'll ask you for their names again because I know that program not only works with the child, but looks at the entire diet of the family because
Exactly.
so I know that's
And
very important.
I will actually
Mhm.
see family members of those children who go to that clinic. They'll come and see me, the adults in the family. Yeah, and because it is all intertwined, and when a child is suffering from obesity, we can look at, a child doesn't necessarily make their food decisions all the time. They don't go grocery shopping. And so we have to, fix it at the parental level a lot of times.
Mm-hmm. I know we have a few minutes left. What are some of the frequently asked questions that you hear about obesity from your patients?
So other than some of them that we mentioned here, is one of the most popular one is, am I going to be on this medication for the rest of my life? And I've already answered that earlier on, so I won't go back to it. But a big one is also, what is the best diet to treat obesity? And I would say that the general healthiest diet that is still recommended is the Mediterranean diet. And that is because it is high in lean proteins, so fish, chicken, turkey. It is high in complex carbohydrates, so a lot of lentils and chickpeas and legumes, and it is lower in is higher in proteins as well, and lower in carbohydrates. And so really when you're looking at, and I'm sure there's going to be research on this down the line and how we process our carbohydrates and calories, but when you're looking at how to eat healthy, The Mediterranean diet is pretty much a very good starting point. And there's a lot of information about it online. There are free, I'm sure you can find books on it, even at your library, if you want to take something out for free and have a look and read about it. But it's pretty much the gold standard when it comes to diets. Or I don't even like the word diet, but when it comes to what you're supposed to be eating.
Mhm. And I have to say something that I've done for years with my cell phone. In the morning, there's a little message that says, "Don't forget to drink your water." And a couple hours later, it'll say, "Cut out the sugar." So you can send messages to yourself. I'm sure there's a fancy app to help keep you on track, but you know what you need. I know what I need, so I put it in the app. I even have sometimes don't talk so loud because people say I talk loud, but you can put your own message in to remind yourself, have I exercised today? Or if you're at your desk, do some squats. So they're just little things that if you need to do that, well, we all need a little bit of exercise. We all need water. You can just things that you can do for yourself. We have 1 minute left, Dr. Bernotis. Oh, you know what I didn't say? Contact information. How can we
Yeah.
contact you?
Yeah, of course. So call our office. That's the easiest way to get in touch with us. And our phone number is 716-859-1168.
Gonna have you
You
say
do,
it one more time,
yeah,
please.
716-859-1168. And you do not need a referral to see me. If you're going through surgery or you want surgery, then you would have to get a referral from your physician, your primary care doctor. But in order to see me to discuss non-surgical options, you do not need a referral. So you can just call and schedule an appointment. And the sooner the better because we're booking out.
And what are your office hours?
Monday through Friday, 8 a.m. to 3:30. And we're currently located in Buffalo General Hospital, and we will be opening up another office in Williamsville in the spring.
And do you do telemedicine? Can someone talk to you that way?
I do, but it's limited because of the nature. So we like patients to be weighed on our scale because it differentiates fat versus muscle, and if you don't have a similar body composition scale at home, it makes it difficult. But surely I can accommodate patients in between visits with some telehealth if they really need it.
All right. Well, I know we are out of time. Dr. Bernotis, Director of Obesity Medicine at Kaleida Health. Thank you so much for being our guest. I know it will not be our last conversation, but again, thank you for taking time from your busy schedule.
And thank you for having me.
Thank you. And I want to thank our listeners today for tuning in to the Great Lakes Health Radio program on Power 96.5 FM, WUFO 1080 AM. Next week, you'll hear from my esteemed colleague, Cindy Bass from Erie County Medical Center. And in 2 weeks, God be willing, you'll hear me again, Francesca Messiah, Manager Workforce Development. And remember, if I see you in the community, when I see you in the community, I'm going to ask you, is there a topic that you would like to hear? Thank you. Be well, be safe. Bye-bye.